What if we could predict disease outbreaks, like COVID-19, say, days before people even feel sick or think about getting a test? Imagine having that kind of early warning.
It would be a huge advantage, absolutely.
Well, today we're taking a deep dive into something called wastewater-based epidemiology, or WBE. It's this really powerful, non-invasive public health tool. Basically measuring stuff in sewage to see how healthy a whole population is.
That's the core idea.
And we're focusing on a specific, really interesting news study. It's from the University of Kentucky by Strike and colleagues, just out in 2025. They did this rigorous comparison, head-to-head, of two wastewater sampling methods for SARS-CoV-2. You've got the traditional composite sampling versus this simpler, much cheaper method called passive sampling.
Right.
And they tested them in two really different places: long-term care facilities, LTCFs, and these big community wastewater treatment plants.
Very different environments.
So our mission today, for you listening, is to really understand how these methods work, what their, pros and cons are, and what this research might mean for the future of watching out for diseases, especially for vulnerable people, and maybe in places without a lot of resources.
Sounds good.
Okay, so let's unpack this a bit. WBE. At its heart, what are we really talking about? It's environmental surveillance, right?
Exactly. Environmental surveillance. You're measuring these biomarkers, like fragments of virus RNA, in wastewater, and using that data to estimate how many cases might be circulating in the community that contributes to that wastewater.
And why is that so important? I mean, don't we have clinical testing?
We do, but WBE has some key advantages. Critically, it captures data from people who are only mildly sick or even totally asymptomatic, people who might never get an official test.
Ah, okay. The ones who fall through the cracks of the clinical system.
Precisely. So WBE can give us a less biased, kind of broader view of what's actually happening in the community. And that's becoming even more important now, with so many people using at-home tests. The official clinical numbers might not be telling the whole story anymore.
That makes a lot of sense. Okay, so the traditional way, the established method for collecting these samples, how does that work?
Right. The traditional method uses automatic composite samplers. Think of them as sophisticated programmable pumps. They're set up to collect small amounts of wastewater at regular intervals over a set period, usually 24 hours.
Like how much, typically?
Oh, maybe like 100 milliliters every 20 minutes or so. It adds up to a pretty large time average sample by the end of the day.
So you get a really representative picture over that whole 24 hours.
That's cool, yeah.
But I'm guessing there are downsides. You mentioned cost earlier.
Big downsides. Cost is a major one. An auto sampler like that can easily run you about $10,000.
Wow. $10,000.
Per unit. And on top of that, they need special equipment to install, and you need trained people to operate and maintain them. It's quite involved.
Okay, so not exactly something you can just pop up anywhere.
Definitely not. These financial hurdles, the logistical complexity, it really limits where you can deploy them. Think remote areas, rural communities, or even just monitoring specific buildings like schools or nursing homes. It's often just not feasible.
Right. Which brings us to the alternative this study looked at, passive sampling, sometimes called more swabs.
Yep, that's the one, more swabs.
How do these work? They sound much simpler.
They are incredibly simple. It's usually just an absorbent material like basic cotton gauze sponges, sometimes other materials, and you just hang it on a string right there in the flow of the wastewater.
Should hang in there?
Pretty much.
Yeah.
As the wastewater flows past or through it, the material soaks up and kind of accumulates whatever's in there, including those virus fragments we're looking for.
Okay, if the auto sampler is 10 grand, what's the price tag on a string and some gauze?
Get this, about $3.
$3 versus 10,000?
Exactly. It's a massive difference. Plus, you don't need any special training or fancy equipment to deploy them. They basically give you the simplicity of just grabbing a single sample. But because they sit there over time, they offer some potential for capturing signals continuously. A bit like the composite samplers, but way, way cheaper.
So it's easy to see why they'd be attractive, especially for places without big budgets.
Absolutely. Low resource settings, individual facilities.
Yeah.
It opens up a lot of possibilities.
So the study's main goal then was to really put this cheap, simple, passive sampling to the test against the expensive gold standard composite method to see if it could actually deliver, sensitive enough results for tracking SARS-CoV-2.
That was the core question. Yes. Can this affordable alternative hold its own?
Okay, let's dig into where they tested this. First up, Long-term care facilities, LTCFs, really critical places, obviously, with vulnerable residents.
Hugely important setting for surveillance.
So how did the researchers set it up there?
They picked 2 LTCFs in Lexington, Kentucky. And in each one, they set up both sampling methods right alongside each other. So they had the automatic composite sampler running, and at the same time, they had these passive Moore swabs deployed in the same wastewater stream.
Running them concurrently.
Smart. Yeah, getting directly paired samples. This was done between December 2021 and January 2022. They ended up collecting 53 pairs of samples in total across the 2 sites.
Okay, 53 pairs. And the big question, how did they compare in terms of just detecting the virus? Did the passive swabs find it when the expensive samplers did?
Well, the results were pretty interesting. The passive samplers actually detected more positive SARS-CoV-2 signals, 29 positives for passive versus 22 for the composite method.
Really?
Yeah, slightly more. Now, statistically speaking, that difference in the proportion of positive samples wasn't quite significant overall. The p-value was 0.146.
Okay.
But the study did find what they called a fair level of agreement between the 2 methods. They used a kappa statistic for that. It was 0.369.
So, fair agreement. Meaning they often agreed, but not perfectly.
Exactly. It suggests that, yeah, passive sampling is definitely a reasonable alternative for just detecting the virus, especially if composite isn't an option.
But you said passive detected more. And I remember seeing something about low concentrations.
Ah, yes. This was a really key finding. When they looked specifically at samples with low concentrations of the virus, defined as below 180 genome copies per milliliter, or GCML, passive sampling showed a significant sensitivity advantage. Meaning there were more instances where SARS-CoV-2 RNA was found only by the passive sampler but not by the composite sampler when the virus levels were very low.
Huh. Why would the cheaper method be better at picking up faint signals?
The thinking is that the passive samplers might act as sort of pre-concentrator.
Pre-concentrator.
Yeah, imagine that gauze sponge just sitting there, soaking things up continuously over hours, maybe even a day. It's constantly accumulating the target material from a large volume of water passing by. This could effectively concentrate the virus fragments onto the swab, essentially lowering the minimum amount needed in the water to get a positive hit in the lab test.
Okay, that makes intuitive sense. Like it's grabbing tiny amounts over a long time and holding on to them.
Precisely. So it could boost the signal from low levels.
What about the actual amount of virus they measured? The concentration levels, did they differ?
They did. At one of the facilities, LTCF1, the passive samples had significantly higher average SARS-CoV-2 concentrations. It was about 451 GCML in passive compared to only 138 GCML in the composite samples.
Wow, that's more than 3 times higher on average.
It is. Now, at the other facility, LTCF2, the distance wasn't statistically significant, but the trend was similar. Overall, pooling the data, passive sampling still yielded higher average concentrations, roughly 268 GCML versus 151 GCML for composite.
So generally higher readings from the passive swabs. But does that mean they're just better? Or is something else going on? How do we know it's a fair comparison if the amounts are so different?
That's a crucial question, and the researchers looked into it by measuring something else. Crassphage?
Crassphage, what's that?
It's a type of virus, a bacteriophage, that infects common gut bacteria. It's incredibly abundant in human feces, so it's often used as a biomarker for basically the amount of fecal material in the wastewater sample. It helps normalize the data.
Okay, like a control measure.
Sort of, yeah. It helps understand if the sampler is just picking up more stuff overall. And what they found was really striking. Crassphage concentrations were significantly higher in all the passive samples compared to the composite ones. We're talking orders of magnitude higher sometimes.
Orders of magnitude.
Yeah, like in one comparison, it was 2.21 times 10 to the 7th GCML in passive versus 5.66 times 10 to the 5th in composite. Huge difference.
Okay, so the passive swabs are grabbing way more fecal matter proportionally. What does that imply?
It strongly suggests that passive samplers might preferentially concentrate the solid fraction of the wastewater.
Solids. Okay. And why does that matter for SARS-CoV-2?
Because the SARS-CoV-2 virus, or its RNA fragments, can be present in both the liquid and the solid portions of wastewater. If the passive sampler is mostly grabbing solids, it might give you a skewed picture of the true relative abundance of the virus in the overall wastewater flow.
I see. So the higher virus concentration in passive samples might partly be because it's sucking up more of the solids where the virus might be concentrated.
That's the concern. It introduces a potential bias. It also makes it really difficult to calculate an accurate concentration of the virus per liter of actual wastewater because you don't know exactly how much water flowed past the swab or the specific, binding kinetics, how readily the virus sticks to that gauze material versus staying in the liquid.
So great for detection, maybe especially at low levels, but harder to get precise quantity measurements.
That's a good summary of the challenge, yes. For absolute quantification, it's tricky.
Okay, so that's the picture at the small-scale facility level. But the study didn't stop there, right? They went bigger.
Exactly. They also took this comparison to a large community-scale wastewater treatment plant, a WWTP, in eastern Kentucky. This was later, between September and October 2022.
And how did they set that up? Still side by side?
Yep. Composite sampler near the plant's influent, and then they put 3 passive samplers nearby, interestingly, at different depths in the water flow.
Oh, checking if depth mattered.
Seems like it, yeah. And this was important because, as they noted, it's the first study to really compare these methods head-to-head at both the individual facility scale, like the LTCFs, and this large community WWTP scale.
Covering both bases. So what did they find at the big plant? Did passive sampling still perform well?
It performed even better, relatively speaking. At the WWTP, passive sampling significantly outperformed composite sampling in terms of the average SARS-CoV-2 concentration detected.
Significantly outperformed. How much better?
The difference was statistically significant. P = 0.0156. And sometimes the average concentration detected by the passive swabs was more than 5 times higher than what the composite sampler picked up.
5 times higher? That's huge.
It is. And interestingly, the depth they placed the swabs at didn't seem to make a significant difference to the results.
Suggesting the water was pretty well mixed at that point.
Exactly. It points towards the wastewater being fairly homogeneous at that large community scale, which makes sense.
Okay, so passive does well LTCFs, maybe even better at detecting low levels, but it really shines, concentration-wise, at the big WWTPs. Why the difference? Why would it perform even better at the larger scale compared to the composite?
It likely comes down to something called the wastewater matrix effect.
The matrix, like the wastewater itself.
Pretty much. Think about it. Wastewater from a large community travels through miles of sewer pipes before it reaches the treatment plant. All that travel time, all the mixing and turbulence, it tends to homogenize the wastewater. Everything gets blended together really well. So any sample you take at the WWTP influent is probably more representative of the average signal from the entire population feeding into it.
Right, but at a small facility, like an LTCF.
It's different. You've got much lower flow rates, much shorter pipes. The wastewater doesn't have as much time or distance to mix. Plus, you get these sudden slugs of different stuff hitting the system, maybe a load of laundry detergent, cleaning chemicals, different times for peak bathroom use. It makes the wastewater much more variable, more heterogeneous.
So the signal can jump around more, and maybe the composite sampler, taking little sips over time, gets a different average than the passive sampler soaking continuously?
That could be part of it, yeah. The heterogeneity at the smaller scale might affect the 2 sampling methods differently, potentially explaining some of the performance variations we saw between the LTCFs and the WWTP.
Okay, that makes sense. Different environments, different wastewater characteristics. So we've seen how the methods compare in detecting the virus, but the real payoff, the reason we do this, is to connect it to actual illness, right, to clinical cases. How well did this wastewater data predict what was happening with people getting sick?
They looked at that specifically at LTCF2, comparing the wastewater signals, both passive and composite, to the clinical test results reported by the facility. And they found some significant correlations. Both the composite and the passive wastewater signals showed a significant correlation with the number of clinical cases reported 4 days later.
4 days later, so the wastewater signal came first.
Yes, that's the crucial early warning aspect. The signal in the sewage predicted the rise in documented cases 4 days in advance.
That's exactly what you hope for with this kind of surveillance.
Absolutely.
Now, clinical data can be messy, right? Especially with weekend reporting lags and things like that. Did they try to account for that?
They did. They applied a 3-day rolling average to the clinical case data, basically smoothing it out to reduce those day-to-day fluctuations, like fewer tests reported on a Sunday, for example.
And what happened to the correlations then?
This is where another interesting difference emerged. With the smoothed clinical data, the passive sampling signal still showed significant correlations, including a lead time. They even found a significant correlation with a 5-day lead.
Still predictive, even with smooth data.
Yes. But the correlations for the composite sampling signal, they dropped below the level of statistical significance when compared to the smoothed clinical data.
Oh, so the passive method held up better when trying to match the smooth trend.
It appears so based on this data. It suggests that passive sampling might actually be potentially better suited for tracking those broader trends in virus presence within a facility like an LTCF, especially when your clinical data isn't perfectly consistent day to day.
Interesting. More robust for trend tracking, perhaps.
Potentially, yeah. Now, there was one caveat they mentioned. Most of the clinical cases during their study period, like 80 to 89%, were actually among the employees of the LTCF, not the residents.
Ah, so the wastewater is capturing everyone in the building, residents and staff, but the clinical cases were mostly staff. Could that mess with the correlation?
It could introduce some noise or variability, sure. It's hard to perfectly align the contributing population with the tested population sometimes. But even with that caveat, the lead times, especially for passive sampling, were pretty clear.
Okay, so let's try to pull this all together. If you had to state the core conclusion from this strike et al. Study, what would it be?
I think the main takeaway is that passive sampling really proved itself as a viable and obviously very cost-effective alternative to traditional composite sampling for SARS-CoV-2 surveillance in wastewater.
Viable and cost-effective.
Yes, especially in settings where resources are tight or where you want to monitor individual facilities like LTCF, schools, dorms, places like that.
And it does this without sacrificing the ability to detect the virus.
Right. The study showed it doesn't compromise the overall detection outcomes. In fact, as we discussed, it seems to offer a significant advantage in sensitivity when virus concentrations are very low.
Plus, it's simple.
Yeah.
It's cheap. It basically makes WBE much more accessible.
Exactly.
Yeah.
It lowers the barrier to entry significantly, potentially allowing many more communities and facilities to benefit from this kind of early warning surveillance.
Sounds almost too good to be true. But you mentioned some limitations earlier, right? It's not perfect.
No, it's not perfect. There are definitely limitations in areas where more research is needed.
Like the quantification issue.
That's a big one, because you don't know the exact volume of water that passed through or interacted with the passive sampler. Calculating a precise concentration, like virus copies per liter of sewage, is really challenging. You get a signal, you can track trends up or down, but getting an absolute number is difficult.
Okay, so trend tracking, yes. Precise numbers, maybe not yet.
Right. And then there's that potential bias we talked about, the fact that they seem to preferentially concentrate the solids.
Krasfeed finding.
Exactly. That could affect how accurately the sample represents the mix of virus in both the liquid and solid parts of the wastewater. We need more research on that.
What else needs more work?
Well, understanding the adsorption kinetics better, basically. How quickly and strongly SARS-CoV-2 virus fragments actually stick to different passive sampling materials. Does gauze work best? Are there other materials? How does flow rate affect it? Things like that still need more investigation.
So still some refining to do.
For sure. But the potential is clearly there.
So for you, the listener, what this research really highlights is a very practical, powerful pathway towards more proactive health monitoring in our communities. WBE, this sewage surveillance, it can give us those early warnings, spot those hidden asymptomatic cases. It offers a much fuller picture of disease spread than just relying on people showing up sick at the doctor's office. And the development of these simpler, vastly cheaper tools like passive sampling, it makes this powerful surveillance so much more feasible, potentially bringing it to communities and facilities everywhere, not just those with big public health budgets. It could really help level the playing field.
Well said. It democratizes the technology in a way.
It's really quite incredible, isn't it? Thinking about the foresight that looking at wastewater can provide, especially with these kinds of innovations like passive sampling, giving us that early peek, that heads up about community health.
It is. And while we've talked about the challenge of getting absolute numbers with passive sampling, its proven ability to detect the presence of the virus, track the trends, and provide those crucial early warnings that alone makes it incredibly valuable for public health decision-making.
Absolutely. Which leads to a final thought, maybe.
Okay.
We've talked about composite having its strengths, maybe better for quantification sometimes, and passive having its strengths cost, simplicity, sensitivity at low levels.
Right, they have different profiles.
So consider this. How could we maybe integrate both? How could public health systems strategically deploy traditional compass sampling and these innovative passive methods, leveraging the unique strengths of each. Could that combination allow us to build an even more robust, more cost-effective, and maybe more equitable early warning system, not just for COVID, but potentially for any infectious disease outbreak that might come our way in the future?
That's a really interesting thought, combining the strengths, using the right tool for the right job, maybe. A hybrid approach.
Something to